Okay, so I just wanted to make a little video here to talk about some serotonergic and well, I guess some antidepressant pathways, not just serotonergic pathways. So, anyways, when we look at this here, it can look a little messy, and I'm sorry about that. But basically, looking here first, we can see that this is a 5-HT neuron with its cell body in the Raphe nucleus. That means it's a serotonergic neuron because 5-HT means serotonin. And all serotonergic neurons have their cell body in their Raphe nucleus. And if we look at the synapse here, basically, all these dots here that I put, that's serotonin, and it's being packaged in vesicles and excreted out into the synapse. And what happens is, as there's an abundance of it, um, it will get sensed by the serotonin reuptake transporter, the SERT, and standard SSRIs, selective serotonin reuptake inhibitors. They um, antagonize the SERT, so they make it less likely that serotonin is going to be reuptake, and then therefore there's a higher density of serotonin in the synaptic cleft. Now, I on the same picture here, I did include Buspar and the 5-HT2A receptor. And I did that because it's just good to know what the heck Buspar is, since it gets used so much and kind of thrown around on people. It's not the strongest medication. I don't actually reach for it that much unless people say that they have to have an anxiety medication, that they don't feel depressed, and that they don't buy your BS about how antidepressants are the first line agents for anxiety, and they want to be able to go on Google and have Google tell them that their medication is for anxiety and not depression. Then Buspar is great for that because it's the only non-benzo that actually is like just for anxiety. And what Buspar does is it does a partial agonism to the 5-HT2A. So remember, with partial agonism, low doses can be activating, but high doses are somewhat antagonizing. And what 5-HT2A is it's an autoreceptor. So it senses when the density of the neurotransmitter is getting too high, and it just stops the release of that transmitter. So if you antagonize that process, you can allow the cell to put out more neurotransmitter, so more serotonin. So in this way, that you can, in both methods, basically SSRIs often get used with Buspar, and the reason for that, or the theory around why that gets done, is the idea is it can really kind of sandwich the serotonin in there. So we're stopping the reuptake with the SSRI, and then we're stopping the auto sensing with the Buspar. And the idea is that hopefully you would get enough of an effect that it would help the patient. Now going over to the other side here, where I wrote Wellbutrin. Wellbutrin has a similar mechanism to the SSRIs, except for the fact that instead of serotonin reuptake, it's antagonizing the norepinephrine and dopamine reuptake, so the NERT and the DAT. And I don't know why it's called DAT, not DART, but dopamine transporter. Anyways, it's a very similar thing, except it's with the two other neurotransmitters that tend to be targets for antidepressants. So hopefully this quick little video is able to explain to you sort of a couple of things about SSRIs, Buspar, and Wellbutrin.